throughout the both lung filled. His blood abdomen was distended but soft. Urine analysis, protein plus, glucose 2 plus, hematology, hemoglobin of 11, and WBC high. Sodium normal, potassium looks normal, and everything is normal here. DSR is on the little bit higher side, 35. CRP is also raised. Urea of 6.4. Bilirubin higher side, 31. AST normal. ALP raised. Albumin is on the normal side. Protein normal. Magnesium 0.64 is normal. Calcium low, 2.1. Phosphate of normal. Normal or low? Low. Spirometry, FEV 160%, FBC 80%, obstructive picture, and PEF of 350. KCO of 70% of predicted. Answer?
Cystic fibrosis.
It is cystic fibrosis.
Yeah.
So sweat test.
This boy has a cystic fibrosis. He has had a recurrent chest infection secondary to the bronchiectasis confirmed by the examination finding and the chest x-ray. Also note long line inserted via the left antecubital fossa. He is small for his age and has nasal polyps, which occurs in 1/3 of the patient with cystic fibrosis and clubbing. Pulmonary function test shows the airflow obstruction. He has mildly deranged liver function test secondary to the obstruction of biliary ductules in the liver. He has eventually lead to the cirrhosis. He has glucose in his urine. Pancreatic islet cells are destroyed and the pancreas becomes fibrotic, resulting in the cystic fibrosis related diabetes in the 30% of the patient by adulthood. The diagnosis of the cystic fibrosis is made by a sweat test and the genetic analysis. A sweat chloride concentration over the 60 millimole per liter is the indicative of the cystic fibrosis. Treatment is with pancreatic supplement and the prophylactic inhaled or the nebulized antibiotics, strict glucose control, mucolytis, DNAs, and the regular physiotherapy with postural drainage, and the prophylactic erythromycin is used for its the immunomodulatory effect. Non-invasive ventilatory may be used in the patient with the chronic type 2 respiratory failure as it leads to the lung transplantation. Lung transplantation is considered as a treatment option once there is a severe respiratory compromise. Which of the following is the most likely underlying cause of her chest symptoms? 45-year-old woman is referred to the respiratory clinic for review. She has a history of SLE for which currently treated with the hydroxychloroquine, but she continues to have the multiple joint pain and the photosensitive rash. Over the past few weeks, she has suffered from the increasingly severe left-sided pleuritic chest pain and chest ache. On examination, her BP is 155 by 85 and the pulse of 75 and regular. There are decreased breath sound on the left face of the auscultation. Investigation: hemoglobin of 12.1, WBC 10.5, platelet of 155, sodium of 137. Okay. Potassium 4.4, creatinine is higher side, ESR is raised, a small left pleural effusion. Which of the following is the most likely underlying cause of her chest symptoms? Pleuritis, yes. Pleuritis is the most common manifestation of SLE-related lung disease. Up to 60% of the patients with SLE may report pleuritic chest pain with or without the concomitant pleural effusion. Pleural biopsies are rarely performed, and although when they are usually to exclude the alternative diagnosis, non-specific inflammation is seen. Which of the following likely diagnosis? Yanka positive.
GPA or EGPA?
Yeah. What is the which of the following initial action is most appropriate in this case? 20-year-old man has recently started work in the bakery section of his local supermarket. He complains of increasing shortness of breath, cough, and the wheeze during the course of the working week.
Occupational asthma.
And these symptoms resolve somewhat at the weekend and improvement markedly during the week's holiday in Spain. Examination in the clinic on the Monday morning revealed no evidence of wheeze. Peak flow is 520. Predicted is 540. Which of the following initial action most appropriate in this case? 2-hourly peak flow recordings and
BB.
It is important to establish the relationship of the deterioration in the peak flow to work period, as there is a suspicion of the occupational asthma here. Occupational asthma is in bakers may occur due to the floor dust or to the other allergens used in the making the breads and cakes. Review of the workers' work pattern, allowing for the removal of the exposure to the potential allergen, is optimal therapy of the course with the cooperation of the employer. Which of the following test is the most appropriate first line investigation? 30-year-old man with grade 3 MRC dyspnea had a transthoracic echocardiogram showing the severe pulmonary hypertension with the normal left ventricle size and the normal function of all the heart valves. A chest X-ray ordered for the GP showed the clear lung field, and his lung function tests were within the normal limit. On the examination, his BP is of the 145/79. His pulse of 80 and regular, the BMI of 32, the chest is clear on auscultation. There is a bilateral pitting edema of the both legs and the marked varicosities on the left leg. And he tells you the legs have been swollen and painful intermittently over the past year. Which of the following?
Chronic PE.
Cardiac catheterization.
I think of chronic.
It's primary pulmonary hypertension.
How about A?
Right heart catheterization.
What's the option E?
Yeah, it's
Right heart catheterization.
Ultrasound. Chronic PE. Yeah.
It is important to determine whether the pulmonary hypertension is primary or secondary, because any underlying cause of the secondary pulmonary hypertension may be the treatable. Primary pulmonary hypertension is associated with connective tissue disease, vasculitis, HIV infection, and the use of the appetite suppressants, fenfluramine. But there are no clue in this question pointing towards this associated feature. Given that the question alerts us that the patient has a bilateral leg edema as well as the left leg varicosities, this gives a clue that this likely secondary pulmonary hypertension and possible due to the chronic venous thromboembolism. Therefore, ultrasound scanning is the lower limb of the confirmed left leg deep vein thrombosis and of the abdomen to look for any potential sources of the inferior vena cava obstruction. Bilateral leg edema would be the prudent, as these are widely available non-invasive investigation. I think I did not read the last part of the question, sorry. The bilateral pitting edema of the both legs, okay. First read the whole question, then go for the answer, don't jump it. Jumping problem is make us difficult. Okay. In addition to the basic resuscitation, what action would you take? Let's see the scenario here. 50-year-old woman undergoes the routine cholecystectomy. Her preoperative full blood count was normal, and her operative progress was unremarkable, other than a small postoperative bleed that settled with the simple pressure to the wound. You are asked to see her, as she has become confused and she has no previous medical history of note and work as a computer programmer. On examination, she is disoriented in the time and place, the temperature of 37.9, pulse of 110. blood pressure of 110/70, respiratory rate of 24, and the heart sound are normal, and jugular venous pressure is not raised. Chest reveals some bronchial breathing on the right lower and the middle zone. Her oxygen saturation is 91% on the air. Abdominal examination reveals the mild tenderness around the operative scar, but is otherwise normal. Investigation all looks normal here. CRP is very raised, 272, and creatinine is also raised. Sorry, potassium normal, and platelet is raised 790, and WBC of 12.3. A blood film shows the dramatic increase in the platelet with the many enlarged forms. There is an increase in the left to right side, left shifted granulocyte, including the metamyelocytes, myelocyte, and the promyelocyte. In addition to the basic resuscitation, what is the action you take? Aspirin and 300 milligrams, ceftazidime 1 gram twice daily intravenously, aspirin 75 milligram, hydroxyurea 1 gram twice daily, apheresis to reduce the platelet count.
Essential thrombocythemia.
And anticoagulation with the heparin to the therapeutic levels, and broad spectrum antibiotic intravenously.
What about the blood picture? Blood picture. He's febrile, confused. If platelet came low, I will say this TTB. But platelet is very high.
Doses. Yes, platelet increase, right? So give aspirin and hydroxyurea.
Sepsis. We'll go with sepsis.
Sepsis. Okay.
This patient has a developed post-operative pneumonia, which is making her confused secondary to the hypoxia. The patient, the platelet count is raised secondary to infection. The normal pre-operative count makes a primary hematological diagnosis is unlikely in the extreme. The left side, the left shift is also secondary to the infection. First line therapy in this situation depends upon the presence of the absence risk factors for the multi-drug resistant pathogens, knowledge of the local predominant pathogens, and the patient's prior microbiology result. Additional consideration to treating the anaerobic bacteria must be made if the aspiration pneumonia is a possibility. Which investigation would be the most useful in making the diagnosis? A 31-year-old lady presented to the respiratory outpatient department with a 3-year history of increasing shortness of breath and cough. She had required numerous courses of antibiotic. In the last few years, she has a smoker of 5 per day for about 5 years, and the respiratory examination revealed the hyperinflated chest and the mild wheeze throughout, FEV1 of 50%, FBC of 80%, obstructive feature, TLCO low and KCO is also low, RV TLC increase, there is obstruction, which in investigation. Yeah, again it is the repeat one. Yeah, repeat one question. Which of the following is the most appropriate next long-term intervention for the asthma as per NICE? 52-year-old woman with the long history of asthma comes to the clinic for review. She is currently taking 500 microgram of fluticasone and salbutamol. She complains of a further exacerbation and prescribed her oral prednisolone. This is her 8th course of oral steroid. Over the past 3 months, Other history of note includes the vertebral fractures diagnosed following an episode of the acute pain some 3 months ago. On auscultation of her chest, there is a wheeze and throughout the both lung field. Investigation hemoglobin of 12.3, WBC of 5.3, and platelet Other history of note include the vertebral fractures diagnosed following an episode of acute pain some 3 months ago. On auscultation of her chest, there is a wheeze throughout the both lung field. Investigation hemoglobin of 12.3, WBC of 5.3, platelet of 201, sodium of 139, and potassium of 4.5. T score of -2 and PEFR 70% predicted. Which of the following is the most appropriate next long-term intervention for her asthma as per the NICE guideline 2017?
D, Montelukast.
Yes. Montelukast is the leukotriene receptor antagonist. The trial recommended where the patient is fail control the low dose inhaled corticosteroid regimen as per the NICE guideline. Which of the following is the most useful next investigation? Alkaline phosphatase, stool culture, sodium, sputum culture, urine plasma osmolarity, urine antigen testing. 71-year-old man present to the ED. He has suffered from a dry cough and diarrhea over the past few days and is now drowsy and confused. According to his wife, they have recently returned from the winter holiday to the Spain, where they spent 3 weeks staying in a hotel. He has past history of hypertension and the inferior myocardial infarction, although he has had no ongoing symptoms of ischemic heart disease over the past few years. And the examination revealed a blood pressure of 103 by 82 and a pulse of 95 and regular. His stomach is 8.4 and there is a left-sided wheeze on auscultation and the evidence of the left-sided consolidation. Respiratory rate is elevated at the 34 bpm and he looks unwell. His abdomen is soft and there is a minor left-sided tenderness on the palpation. Investigation hemoglobin of 13 and WBC of 14.1 and platelet normal, CRP raised, sodium low 130 and potassium of 4.5, creatinine 112, glucose of 6.1, X-ray right-sided patchy basal consolidation, pleural effusion. Yeah.
Yeah. I guess all is pen air conditioner full of ligament.
Yeah. Which of the following is likely to be the most informative with respect to the determining her suitability for surgery? A 54-year-old man has a left side adenocarcinoma of the bronchus confirmed on transbronchial biopsy. She tells you that she has lost weight over the past few months and has had nagging cough, particularly in the morning, but has actually has still been able to hold down her job, riding her bike the short distance to work and caring for her teenage children. Investigation hemoglobin of 13.5 and all looks normal here. Which of the following is likely to informative with respect to the determining her suitability of for surgery? Yeah.
Yeah, as well.
Look
She's
for
riding her bicycle. No need for
yeah.
pulmonary function.
Yeah. First, we have looked for some staging. No? We go for the staging.
Yes, first.
PET-CT combined scanning offers the best imaging modality to determine the lymph node involvement in the bronchial carcinoma. In this case, with the good functional status at the point of diagnosis, it's lymph node involvement which is likely to be the biggest determinant of the success or the failure of the surgical intervention.
Lymph node involvement.
What is the diagnosis? Okay. 16-year-old boy. A 16-year-old boy present with the persistent cough productive of brown-green sputum, and he occasionally produces a small amount of blood. His mother said that he had always been suffered from the chest infection requiring numerous courses of antibiotic. He also complained of offensive smelling stool, which were difficult to flush. On examination, he looks the small for his age. Auscultation of his chest reveals the bibasal force crackles, hemoglobin of 11.2. WBC of 10.7, platelet of 5 side, MCV normal, sodium potassium normal. All looks normal. Bilirubin is on the lower side. AST normal, ALP normal. Protein. Yeah. The bilirubin is normal. Yeah. But it is a repeat one. I know that. But they said that globulin. What is the normal range for globulin? If we calculate here, the total protein is 50 and albumin is, okay, the protein in the gamma per dl liter. Okay, in the liter it is 5 and 5 months. Okay. Yeah, it is lower side. Okay. It's a bit 2.5, 2 to 2.5 something in the globulin should be. Okay. Yeah. It is repeat one. Oh shit. 1 minute. Yeah, there is something on the apex region also here. The chest X-ray shows the bronchiectasis, parallel thickened bronchial walls with the tram track appearance. These ones. "30-year-old man from London with no significant past medical history went on the holiday to the Peru to climb the Inca Trail." Here, okay, the same question. How would you treat this patient? Okay.
B.
The night it was noticed that he was disoriented, and it is Hayes treatment.
Descent, huh? Yes.
Acetazolamide and no. Why ascent? They are saying ascent, no ascent.
Yeah, descent.
Immediate transfer down the. Yeah. But
yes.
Okay, we know that with this. Which of the following is the most appropriate intervention for her asthma? 24-year-old woman presented to the clinic with the 9-month history of the nocturnal cough and shortness of breath, particularly first thing in the morning. She worked as a PA in a solicitor's office. She noticed wheezing on a number of the days during the week. She is a non-smoker. Her weight is stable, but she reports the some symptoms of reflux. Salbutamol inhaler used as a she has had a limited impact on her symptoms. Okay, on the examination, her BP is 138/72 per 70. Her chest is clear and BMI of 28. Chest X-ray unremarkable, and her peak flow is 400. For it is predictable. Salbutamol is given only. Yeah, it's nocturnal cough. Okay.
Yeah. Looks like GERD.
Yeah. This patient has the symptoms of asthma, particularly with nocturnal coughs, which are not responsive to PRN salbutamol. As such, the next step is regular inhaled beclomethasone. Although it was previously thought that the proton pump inhibitor are effective at treating the asthma in this situation, a meta-analysis see Webling as challenged that view. Okay. But feature of ERD also. Yeah. Yeah. Which of the following would you most expected to find? 18-year-old male patient with the cystic fibrosis admitted to the hospital with an infective exacerbation of his condition. His latest sputum grew Burkholderia cepacia. His sister has also cystic fibrosis and has problem with abdominal pains. He has previously been relatively well, plays for a local football team, and is in the first year of the law course at university. He has maintained his weight so far. Severe restrictive pattern on the spirometry, exocrine pancreatic insufficiency, diabetes mellitus, low thiamine, and vitamin B12, and symptoms of chronic constipation.
B.
Yeah.
Pancreatic insufficiency.
Exocrine pancreatic insufficiency is a feature of cystic fibrosis and occurs long before evidence of the dysglycemia and frank diabetes mellitus. Pancreatic exocrine supplements and the fat-soluble vitamins ADEC and are the key features of the treatment. Endocrine pancreatic dysfunction leading to a diabetes mellitus occurs later in the disease and associated with weight loss and symptoms of dysglycemia. Okay. What is the most appropriate management step with regard to isolation of this patient? A 51-year-old woman is admitted with the worsening of fever and night sweats over the past 2 months associated with the joint pain and the fatigue. She has been previously well other than the recent attendance of her GP. For a long-standing productive cough some 5 months earlier, travel of the note includes the spell working at a church missing in India during the past year. A chest X-ray was shown is undertaken and the sputum sample are awaited. Hemoglobin of 10.1, WBC of 3.4, neutrophil of 1.98. What is the most appropriate management step with regard to isolation of this patient? Isolation in the negative pressure room, isolation in the positive pressure room, isolation in statin. Oh, answer is not here. No one's.
Sarcoid base.
Which investigation would help to confirm the diagnosis? 39-year-old man presented to his GP with 3 months history of fever, rhinitis, weight loss. 2 weeks ago, he had a exacerbation of asthma and was treated with the course of erythromycin. He also complained of the weakness in his hands and the legs. He has a past medical history of angina. He is an ex-smoker and stopped 5 years ago. On examination, he has a rash on his skin and the zone below. And the auscultation of the chest reveals a mild expiratory wheeze. Examination was otherwise unremarkable. Urine analysis was normal, and the investigation hemoglobin of 12.1, WBC of 10.4, platelet of 411, sodium potassium normal, creatinine is normal, MCV normal. And neutrophil lymphocyte normal, eosinophil is very high, and ESR is high, urea normal, creatinine normal. Which of the following helps?
B, Anka. Myeloperoxidase.
Yeah, answer D.
Yes, true.
Leave this. I don't want to read.
Jarvis Truss.
45-year-old woman is referred by his GP to the respiratory care clinic with the shortness of breath of unknown origin. A spirometry result KCO of 60%, FEV1 of 90%. Which of the following most likely to be underlying cause of the pulmonary function test? Sarcoidosis might be severe kyphoscoliosis, restrictive picture, okay, muscular dystrophy, pneumonectomy, bronchiectasis. Bronchiectasis, no. And pardon?
Why not severe kyphoscoliosis? Restrictive
And
picture with no KCO though.
in pneumonectomy, KCO will be high.
KCO.
Yeah, in bronchiectasis there will be some sarcoidosis. There it is a restrictive picture also.
I guess it's kyphoscoliosis. Why muscular dystrophy?
KCO is the. Why not sarcoidosis? No, sarcoidosis is restrictive picture. No,
Restrictive.
Sarcoidosis is restrictive. It is confirmed.
Yes, restrictive. But KCO is not very low here, so.
Yeah. Let's see. Answer is sarcoidosis. FEV1 by FBC is 90%, indicate a restrictive cause. All of the above diseases are evidenced by a restrictive pattern except the bronchiectasis, which can result in an obstructive pattern. Only sarcoidosis would be reduced the transfer coefficient as there is a damage to the alveolar cells themselves. Other conditions where the reduction in the KCO is reduced include those such as the idiopathic pulmonary fibrosis, where there is also loss of alveolar function. Severe kyphoscoliosis abnormalities of the thoracic case lead to a reduction in the available lung volume for the gas exchange, but don't impact the transfer coefficient. Okay, KC will be higher here. And the muscular dystrophy, similar to the kyphoscoliosis, muscular dystrophy can lead to the restrictive lung pattern, but does not impact the gas transfer. Because these are not a primary lung disease. Okay, so that's why the KCO will be high or normal. Yeah, normal, not high, normal. It will be normal. And the sarcoidosis is a lung disease, so then the KCO will be affected. And pneumonectomy is the most likely to have been performed for the chronic bronchiectasis or the lung cancer, both of which can be unusual in the 45-year-old man. Okay. An expected impact on the transfer factor in the remaining lung would not be expected. Which of the following is the most appropriate intervention? 62-year-old man who has a history of COPD for which he takes the fluticasone and salmeterol, and salbutamol comes to the ED with the sudden onset of shortness of breath and the right-sided pleuritic chest pain. He takes a number of the medication or the hypertension and the ischemic heart disease, but he recently enrolled on a pulmonary rehabilitation program and is walking up to the 2 miles per day. On examination, his BP of the 155/90. Examination on pulse of 92. His diminished breath sound over the right heart sound and auscultation. Oxygen saturation of 90%, and there is a 1.5 centimeter of pneumothorax. Answer. COPD secondary pneumothorax it is.
Secondary. Age more than 50.
Sudden onset shortness of breath is there. Okay.
What is the last option?
There is no drain.
It is the last option.
Chest drain.
Yeah.
Yes.
Yes.
E.
You know that? Yeah. Patient is having symptoms, secondary pneumothorax. Which of the following option is the next management of choice? 65-year-old man present to the emergency department with the acute breathlessness, cough and frothy blood-stained sputum. And he had trying to save his cat from his house, which was on fire when he was overcome and smoke. The firefighters rescued him. On examination, he is dyspneic with blood pressure of 111/62, a pulse rate of 104, respiratory rate 28. On auscultation, he has a crackles in the both lung fields. The abdominal examination is unremarkable. The oxygen saturation of 88% on air. You immediately start the patient on the high flow oxygen, that is 15 liter, and ABG or showing pH of 7.31, low, PO2 of low, and PCO2 of 4.2 on the lower side. Bicarb is 21 kg on the lower side. Oh, sorry. Answer. It is a ARDS.
ARDS.
Yeah. Management. Patient has had an acute insult to his lungs following the smoke and carbon monoxide exposure, which with his chest X-ray appearance is consistent with the ARDS. Given that he is failing his maintained PO2 of more than 8.3 kPa despite the maximal oxygen delivery, the next step would be the intubation and ventilation. Invasive circulatory monitoring is also essential with respect to managing the pulmonary capillary waste pressure and the cardiac output. There is a conflicting evidence of the use of steroid. As such, they are not universally recommended in the ARDS. "62-year-old smoker of 30 cigarettes per day present with the symptoms of cough and dyspnea, accompanied by the vague, non-specific chest pain. There is a general malaise and the joint pain, which has been relieved by the using diclofenac, and his cough has not been improved by the salbutamol inhaler." Here is the picture. There is a non-specific increase in the immunoglobulins and the raised serum S level. Yeah. Look at the image. Yeah. Very beautiful. This one is repeat one. 77-year-old woman was referred to the respiratory outpatient clinic with the increasing shortness of breath. This is again that operation thoracoplasty. Thoracoplasty is done here. The ribs are removed and in situation like tuberculosis. This question is a spot diagnosis, clues that this is a thoracoplasty or that there is evidence of resection in conjunction with the loss of lung volume. The chest X-ray shows the thoracoplasty. This lady has a tuberculosis in the 1940s. Prior to the use of anti-tuberculous chemotherapy, she had a thoracoplasty, which is one of the main surgical treatment for the tuberculosis between 1930 to 55. Several ribs were resected, which reduced the thoracic volume and collapsed the underlying lung. The aim was to close the tuberculous cavity and rest of the lung. Control of the pulmonary tuberculosis and the survival was good. However, patient was left with the severe chest deformity and the associated respiratory compromise, a restrictive defect. What is the most appropriate next step in this gentleman? 19-year-old student brought to the emergency department by his housemates. He has suffered a cough for the past week and using the infusing amounts of his blue inhaler. Ordinarily, he is maintained on the fluticasone, salmeterol combination inhaler, 250 microgram, 50 milligram BD, and montelukast 10 milligram daily. His housemates don't think he is registered with the students' health services and are worried that he may not have filled up his prescription. Clinical features on admission to emergency are respiratory rate of 30, PEFR 230, and the predicted is 590, and the oxygen saturation of 90%. And you commenced on oxygen therapy, given a bolus of IV hydrocortisone and give him the nebulizer containing the salbutamol and ipratropium. The nurses repeat the salbutamol nebulizer 3 times. Clinical features of respiratory rate of 15 and PEFR 230, pH of 7.35, and PO2 of 7.7, PCO2 of 5.8. What is the most appropriate next step for this gentleman? This is a case of severe asthma.
Yes. IV mag sulfate. But the age not contraindicated, huh?
Most appropriate next step, we should go for that ICU team.
ICU
And
admission.
yeah. Then he needs IV magnesium, but we first have to go for that.
But we can put IV بعدين shift him to ICU.
It's quite confusing also for me. Because somewhere they're saying go for the
age is not contraindicated for IV max, huh? There is something like this, or just there is contraindication with IV magnesium.
I don't know about any criteria for the IV magnesium sulfate. They said that first review and in between you can give, but because it is not as much important as to first in.
Yeah, to shift him to ICU first.
Yeah, and the CO2 normal is something dangerous. Yeah,
CO2
dangerous sign. The most appropriate next step in this case would be the review by ITU physician. Despite therapy, this peak flow has deteriorated. He is making less respiratory effort, and there is evidence of hypoxia with hypercapnia. On the arterial blood gas, there is a hypercapnia. It's a normal. They are trying. He is at risk of respiratory arrest and should be assessed for ventilatory support. Magnesium is recommended in the management of acute severe asthma, although it may well not reverse the current deteriorating in this patient's symptoms. Okay, we have to finally go for the ITU. So first we have to go there because magnesium is not going to protect this patient from going to the life-threatening or near fatal one. Just by few minutes. Okay. Left lobe collapse. Okay, we have to do 2 more questions. 72-year-old man is referred to the respiratory outpatient clinic with the 2 month history of increasing shortness of breath and cough over the last few weeks. He has coughed up a few streaks of blood. He has also noticed the difficulty getting up from the chair, and that has clothes are looser recently without trying to lose the weight. He is taking regular inhalers, but he's unsure of their names. On examination, clubbed auscultation chest reveals reduced expansion of the breath sound on the left. Heart sound on normal chest 2 centimeter. He has a 2 centimeter hepatomegaly at the palpation of his abdomen. Reduced power of the hip flexion and the bilateral. There is a generally reduced tendon reflexes. Plantar both shows a flexor response. Proprioception normal. Hemoglobin 10.9, WBC 12.2, and the ESR is raised. Other as normal. Sodium is low. Sorry. AST high. Okay. What is the diagnosis? Yeah. Siad Lamberitin. What is the most likely diagnosis of the cause of effusion? You are seeing a patient, surgical ward, medical referral. He has had a lymph node dissection from the neck for the possible recurrent head and the neck cancer. On the post-operative chest X-ray, he has a moderate pleural effusion, and the milky fluid. Yeah, triglyceride will be raised. Chylous effusion is suggested by the white milky fluid aspirated in thoracocentesis, cardiothoracic head, and the head and the neck surgery, including the excision of the cervical lymph nodes, can result in the damage of the thoracic duct, resulting in the chylothorax. To confirm the diagnosis, test the pleural fluid, triglyceride, and the cholesterol levels. Okay. What diagnosis fits best with this clinical picture? A 52-year-old immigrant from the Balkans present for review over the past few months. He has suffered from a number of fevers and the night sweats and lost a significant amount of weight. On the chest X-ray reveals the small, moderately sized of right-sided pleural effusion. Tuberculin skin test is positive. Tapping of the fluid lymphocytosis, although the staining of the acid fast bacilli is negative, and the protein count of 41. Yeah, it is very poor test for that. Where is Balkan? In Africa or the South America? Yeah? Oh. TB effusion present with the pattern of the symptoms accompanied by the small moderate effusion rich in lymphocyte. Okay, acid and the acid phosphatase staining is 5 to 10% positive. Just culture is 25%, and PCR or TB is done, especially center may improve the diagnostic yield as the many pleural biopsy. Fluid volume may increase during the antituberculous therapy. Corticosteroid associated with the reduced fluid volume, but have no effect on the outcome of the pleural thickening classification. Unfortunately, occur commonly tuberculin skin test, and the fact that it has come from the Balkans are the pointers to the underlying TB. Okay, thank you everyone. We will start at night, that evening, 7 p.m.